Hi, colleagues. Good morning and welcome. And those online, welcome to today's seminar. And I am so excited about it because, again, it's my comfort zone. So it makes me excited to want to listen to this. So I'm hoping that you would be able to enjoy it as well. But before we go on, a few things we have to do. As usual, we have to acknowledge the land on which we are. And so as this is a hybrid event, some participants are on different territories, so please take the time and space to give thanks and gratitude and respect to the land you are currently living and working. Today, I'm here on York campus, York University campus in Toronto, alongside my colleagues here. York University is situated on the traditional territory area on the area known as Toronto, and we acknowledge its current treaty holders, the Mississaugas of the Credit First Nation. We also acknowledge this as the traditional territory of many indigenous nations, including the Anishinaabe Nation, the Haudenosaunee Confederacy, the Orundwenda, and the Métis. This territory is subject to the dish with one spoon, one poon belt covenant, and an agreement to peaceably share and care for the Great Lakes region. So hopefully that helps us situate where we are, and definitely let's commune with the spirits that gave us this land and ensure that what we're going to listen to today, I can imagine there will be elements of that, and have an open mind. I now have the honor and the singular honor to introduce our guest speaker, a renowned person in that order. Marina Morrow is a professor at the School of Health Policy and Management in the Faculty of Health at York University, and is renowned and an international expert on mental health policy and equity. Her research has developed novel intersectional approaches and academic community management models that have been translated into mental health policy and practice in Canada and internationally. In her work, Marina uses math studies approaches to better understand the social, political, and institutional processes through which mental health policies and practices are developed, and how social and health inequities are sustained or attenuated for different populations. We're glad to have you, Prof, and I'm eager to listen to you and hopefully build some collaborations and relationships after this. So I think we'll have Prof give a talk, and then after that, we'll then have a Q&A and a great discussion. So over to you.
Thank you. Well, thank you for the invitation, and thank you, Benedict, for the welcome and for the land acknowledgement. It's lovely to be here, and I'm looking forward to the conversation. So what I'm going to present to you today is I'm going to give you some preliminary results from a Social Science and Humanities Research Council funded project, which is called Realizing Human Rights and Social Justice in Mental Health. And it involves 3 countries, Canada, Kenya, and Australia. And you might be wondering why those countries. Well, all of those countries have histories that are grounded in very, very different kinds of histories grounded in colonialism. So all of them have experienced colonialism, and they all follow British common law, which will become very important as we go through the conversation to mental health. So they all have the same sort of legislative structure with respect to mental health. So I'm going to start with a little bit of contextual background, describe the study, and then share some of the preliminary results from the field research in Canada and Kenya. I'm not going to share any of the results from Australia today, just because of our time constraints. Before I begin, I just want to acknowledge that this is a massive team. So I'm one person that's part of this big team. And probably what's important to point out is that in each of the locations that we're working in, it's led by an academic and a community partner. So in Canada, we have Eviance, which is a cross-disability rights organization. In Kenya, we have user survivors of psychiatry, and we've also worked closely with persons with disabilities also in Kenya. And in Australia, it's VIMIAC in Melbourne. So we've got a lot of different partners, and a lot of different researchers, research assistants have been involved in this, including some research assistants from communities. So for example, in Kenya, all of the research was conducted by people at that time affiliated with PDO Kenya, as well as my colleague, Mohammed Ibrahim, who's at UBC. So big team and lots. And to add to that, we also have a very big, what we're calling a knowledge user subject expert group. This is an international group of mostly NGOs who are disability rights activists working in the disability rights space. So here's kind of a list of them. Just a note, I've got a star by Bhargavi Davar. She, I don't know how many people are aware of her work. She's been a huge presence in Asia and internationally. She just recently passed away, sadly. So we've lost her, but we've got her colleagues who've continued to be involved. I won't have time to go through all of the knowledge exchange events and knowledge mobilization activities we've done with this group, but I can talk to it in the question period. So I just want to give you a bit of a sense of the rationale. So why were we interested in doing this project and what is it all about? So the impetus from the project, so just to situate myself a little bit, most of my work has been in the domestic space, so mostly in the Canadian context at the intersections of equity, policy, and mental health. And in the time that I've been doing this work, I started doing this back in the early 2000s in BC, where deinstitutionalization was still an active thing. The big psychiatric hospital there, Riverview, was still in the process of moving people out of that institution. And so deinstitutionalization, which is now standard internationally, and recovery models, the introduction of recovery models really promised this idea that we would have a more humane system, a system that would respect the human rights of people with mental health issues. Because we know, of course, institutions didn't work very well, right? That institutions have been problematic and that institutionalization, of course, still exists. So, that promise is there, but despite that, we know that in current context, there are many coercive practices that still exist within mental health care. And so what we wanted to do in this project was to begin to understand the experiences of people in the mental health care system today in these different contexts. So just to highlight a couple of things. So many routine practices are experienced by people as traumatizing, violent, and coercive. And here I'm talking about things like involuntary detainment, involuntary treatment, could involve things like restraints, the use of seclusion, but also kind of more broadly stigmatizing attitudes and discriminatory behaviors. And some of these practices are state-sanctioned practices. So that's part of what I'm going to talk about today through the Mental Health Act. We know one of the key lenses we bring to our work in this project is intersectionality. And so discrimination based on gender, racialization, citizenship, colonialism interacts with people's experiences of mental health. And of course, certain populations are disproportionately impacted by these coercive practices and by mental health human rights violations. And we'll talk about that, but there's also a lot of gaps in the data on this. Canada, Kenya, and Australia are all signatories to UN conventions that are meant to protect people's rights. So for example, the UN Convention on the Rights of People with Disabilities and the Declaration on the Rights of Indigenous Peoples for Australia and Canada. Now, in the face of what sounds like a really bad situation, there are also a lot of, I just want to point out, because it's part of our research, which I won't get to focus on much today, but there are a lot of international non-governmental disability rights organizations that are led by people who identify as having mental health problems or disabilities, who play a really key role in advocacy and in developing sort of better practices in mental health. So a key component of our project, as you'll see, involves looking at those practices. So just to give you an overview of the project itself, there's 3 phases. The overarching goal was really because very little work has been done that has directly canvassed the experiences of people who've experienced involuntary detainment, seclusion, restraints. So we wanted to focus there, but we also wanted to surface what are some of the better practices that are happening internationally. So there's 3 phases of the project. And because of how huge this project is, I'm only honing in on phase 2 and giving you a little bit of a taste of what's come out of the focus groups. The phase 1, and I can send this information to folks. I think you got actually a link to some of the publications that have already come out from the Critical Realist Review and the Environmental Scan, as well as intersectional based policy analysis. So we have a special issue in the journal Studies in Social Justice and a chapter coming out, as well as kind of a cool tool that's on the website, how to use intersectionality. It's a comic essay, actually, on how to use intersectionality in mental health. So those are some of the things that have already happened, but I thought I would focus in on the focus groups. I did want to point out, though, that we also did key informant interviews, and those were interviews with people working in the system, people in the management capacity, people who do policy and legal work in mental health. And then phase 1 and phase 2 are kind of linked in that the exemplars of social justice and equity in mental health were kind of surfaced through the critical realist review. But we have not yet got to this stage where we're developing, taking that material and developing a toolkit for human rights and equity. That's kind of our next thing that we hope to accomplish. So what's the link to colonialism? That's something I wanted to really highlight in the conversation today, and something that I'm learning, or that I'm hoping we'll have a bit more of a conversation about, because the research in this area, although not completely new, there's not that much that focuses specifically on psychiatry and mental health, although historically, of course, there's some really good work in that area, but contemporary work. So what we do know, though, is that psychiatry has been used as a colonial tool to suppress and control Indigenous populations. And just an example here would be in the context of Kenya, one of our sites. They did not get independence from the British colonizers until the 1960s. And psychiatry was actually used as a tool to suppress anybody who was trying to resist British rule. And psychiatry was used to, pathologize the local population through labels of mental illness, for example. So that's one sort of example of how colonialism and psychiatry collide. Of course, we know a lot about this in the Canadian and Australian context, that colonialism has had, serious mental health impacts on these populations, right? Including, this is just one example, disproportionate suicide rates among Indigenous peoples in Canada and Australia. Here's just a little bit of a list of the harms of colonization. It includes, at its extreme end, genocide, but also loss of Indigenous culture and ways of knowing. Now, settlers are also subject to colonial systems. Of course, the impact is different, but I would argue that, this kind of a framework is damaging to all of us, and so therefore should be an important part of our analysis. So mental health laws in countries colonized by the British, so this is all Commonwealth countries, emerged from these colonial histories and continue to impact Indigenous populations and other groups marginalized through racism, poverty, sexism, and heterosexism. And it'll be interesting to also maybe talk a little bit about, I'm not doing this in my talk, but the sort of global health movement and where that kind of intersects with colonialism, because there's a lot of good writing in that area. So I just want to give you a bit of a, for those of you, how many of you are sort of familiar with the Mental Health Act or mental health law? A few people. So just a little quick primer on this in the context that we're working. So the Mental Health Act and its associated legislation is, in the Canadian and Australian context, is determined provincially or territorially. And in Kenya, it's a national law. And what that law is, what that piece of legislation is, it governs when people are considered not to be able to make their own decisions. They can be involuntarily detained and in some cases treated against their will using specific kinds of criteria. So dangerousness to themselves or other. Criteria has been getting looser and looser in some contexts, particularly in the BC context. So mental deterioration. In the Kenyan context, the law even lists something like offense to public decency. So could be very broadly, interpreted. So the number of safeguards with respect to involuntary treatment also vary depending on which province you're in the Canadian context, or which country you're in. And so there's a big debate and tension around the Mental Health Act, and this is a kind of a simplistic, but I think succinct way of describing that. So psychiatry typically supports the Mental Health Act as a necessary tool to ensure community safety and access to treatment. And you'll even hear human rights arguments being made that if we don't involuntarily detain somebody, we would be violating their right to treatment. So human rights language gets mobilized in this instance, as well in the second instance, which I'll describe. So with people, amongst many people, not all, with lived experience and community-based mental health advocates, mental health law is much more controversial because it's the only law we have which really allows you to take away a person's freedoms in a very total kind of way. So it's controversial because of its violation of the right to choice and autonomy, and because of the harms that people experience in the context of mental health care. So another important context is that in Canada, Kenya, and Australia, they've all signed on to the UN CRPD, which is the Convention on the Rights of People with Disabilities. Kenya has signed on fully. Canada and Australia have signed on with some reservations to Article 12, which is related to substitute decision-making. So in Canada and Australia, you can still use substitute decision-making. But we've also signed on to the optional protocol, which is the complaints mechanism that can be used, whereas Kenya has not signed on to the optional protocol. So there's a little bit of differences in kind of what's happened there. It has been argued that domestic mental health laws in all three countries are in contravention of the UN CRPD, based on Articles 12, 14, and 17. And those articles concern, as I said, substitute decision-making, detention, and involuntary treatment. So briefly again, just to let you know how, and this is again, very, very brief high level, but how mental health care is kind of organized in each of these country contexts. So in Canada and Australia, mental health care is funded through the federal government, but the federal governments, transfer the money to the provinces. It's part of the larger health budget. That's been a huge debate and discussion. Should we have a separate mental health budget? But it's typically been part, in the federal context, has been part of the larger health budget. And then it's delivered by the provinces and territories, and in Australia through their states and territories. Kenya is a little bit different. More on Canada. So in Canada, there's a wide range of services. There's inpatient, there's outpatient, there's a whole array of community-based kinds of supports. And we also have both public and private options, right? So you can pay for counseling, for example, or therapy outside of the system. In Kenya, again, the budget is similar. It's part of the overall health budget. It's a very small percentage of the health budget. Very little money goes to mental health care. And there's no government-funded community-based supports. There are some community-based supports that are philanthropically funded, but none that are directly government sponsored. In the Kenyan context, that means that care is primarily delivered still through hospitals. So there's still a lot of institutionalization, particularly the one big hospital in Nairobi, Mathari Hospital. And there also are public and private options in the Kenyan context. But a lot of the care gets done in the context of families, which is somewhat true in Canada and Australia as well. In the Kenyan context, it might also involve traditional or spiritual leaders being involved in care. So what did we do in the field research? So I'm going to focus today on the focus groups themselves. And so the way that we recruited people was through our community partners and various research assistants who were working more closely in the frontline context. And people could only come into the study if they'd had experienced involuntary detainment and some of the other issues that we were looking at. But involuntary detainment was the key thing that would bring people into the study. And so we were we had kind of differing numbers depending on where we were. So in the Canadian context, when this project, just to context, when this project was first funded, we were right in the midst of the COVID pandemic. So we started our field research in BC. The reason you see 6 focus groups there is that we tried some online focus groups so 3 were online and 3 were in person. In Toronto, we did 3, all in person. In Nairobi and Nakuru, which is a medium, Nairobi, of course, is a big city. Nakuru is a medium-sized city. We did 4 focus groups in person. And in Australia, they did 3 focus groups. And I think one of theirs was online and the rest were in person. And these are just the numbers for interviews with people with sort of specialized knowledge of mental health. So just to give you a sense of kind of what do we ask people about. So we asked them to talk about their experiences with mental health care, kind of a broad open-ended question, what kinds of services and supports have people accessed? And then we got into the question about, have you been subject to the Mental Health Act? We knew that everybody coming into the study would have been. Could they describe some of those experiences for us? And then there was a question really about how people felt they were treated. And we wanted to broaden the notion of coercion to discrimination and stigma, because those are things that are often not tracked very well. Mind you, none of this is tracked very well, but stigma and discrimination is something that isn't, routinely kind of tracked, and yet we hear a lot of stories about it, right? So we did ask people more directly about discrimination in the focus groups. And then we had a section where we asked people to recommend changes. So what would they see as the most important things to do different? So who participated? So in Canada, we had a total participant number in the focus groups overall of 43, and in Kenya, 27. And this is kind of loosely the demographics. It's pretty broad here. So we had a mix of men and women. We had an age range, 20 and up. Most people were in the sort of the middle, like 30s to 50s. We had some Indigenous and Métis participants, and I want to say just at the outset, we did not have our team didn't have a well-developed partnership with an Indigenous organization going into the research. So we reached out fairly early on to an organization in BC, and they decided, rather than coming on as a full partner, they wanted us to host an event so that their community could come together and hear about our research and also talk about the issues that they were experiencing. So that was something that we were sort of putting under knowledge mobilization as part of the work. We did have some Black and racialized participants. And in the Kenyan context, although most people were from the dominant tribe there were some different tribal affiliations. We had some people who identified with physical disabilities, and people had multiple mental health diagnoses. I mean, this is always interesting when you do work in mental health. So people would describe themselves as having been diagnosed over the time of their lifetime with number of different things. We had quite a few homeless people, particularly in the Ontario sample, because we had one of the RAs who's a student here works in that sector, and some people who identified as transgender. And then on this side of the slide, you can see the types of services accessed, and it's a wide range. So people, had been in hospital and psychiatric wards. They've been taken in by ambulance. They've been involved with the police. ACT teams are sort of community treatment teams. These are kind of interdisciplinary teams that go out to people's locations to support them. People had access to community-based supports that could include social supports or housing, income-based supports, mental health teams in the Canadian context. And so they came into contact with many different kinds of professionals, counselors, addiction services, and peer supports. So a wide range of we captured a wide range of types of experiences. So in terms of what we wanted to do with this work, so one of the things that we were conscious of in looking at colonization and looking at stigma and discrimination, we wanted to bring both a decolonial lens, but also an intersectional lens for the data analysis. How many of you are familiar with intersectionality as a framework? Quite a few people. So intersectionality, of course, emerged historically from the feminist movement, and particularly in the sort of second wave of feminism from the work of Black and Indigenous feminists who were challenging, the notion that all women had something in common, right? So they were asking the question, which women, who, and how does discrimination play out when you've got multiple intersecting social locations that determine how you're treated and how you're discriminated against. So it's kind of intersecting and interlocking forms of oppression. So we thought, we did a traditional kind of coding of the focus group material through the software Produce, and then we have applied this kind of analytic lens by using these kinds of questions that kind of try to surface some of those intersections. So, of course, we wanted to know just at the basic level, what are people's experiences of this type of care? But we wanted to get a sense of what do people identify as important in their stories? Because, a lot of times I get this question with using the lens of intersectionality, well, don't you have to have this massive, sample of people in order to actually better understand what the impact is? And of course, that is ideal if you're doing like a quantitative study, but in qualitative research, we often have these smaller samples. And so a lot of the literature talks about, well, in those instances, what you're actually trying to get at is what do people themselves identify as important intersections? So you're not asking them that question, but you're looking in their stories to see what did they highlight? Did they highlight that, they were experiencing ageism? They were experiencing, discrimination based on their ethnicity or their class background. So what intersections did they highlight as important in their stories? Some other questions we were curious about is, did people feel that they were able to access the kinds of services they were seeking? Within the context of intersectionality, there's also a lot of focus on agency and resistance. So rather than just seeing participants as kind of victims of their own sort of stories or victims of the experiences, we wanted to also see how do people show agency or resistance in the face of their experiences, and also what kinds of forms of collective resistance might exist, which is a bit of a broader research question. Intersectionality is not just about the intersections, it's really about what the intersections have to say about power. And that quote actually comes from a dear colleague of mine, Rita Damoun, who said this very early on in her career, and I thought that's such a great way of describing intersectionality. So it's not, people get obsessed with, the identities, the intersecting identities, but it's really, what do those things tell us about power and how power is manifesting for people in their stories. We wanted sort of more broadly to understand, how participants understand mental health and mental wellness, and then of course recommendations for change. What are things that people wanted to see done differently? So what I'm going to go through next is to give you a sense of some of the emerging themes. So this is preliminary analysis. So where we're at right now is all the coding has been done, and we're in the active process of analysis, and so it's not a complete finalized version yet, but these are the themes that are coming up, really strongly that I felt we could present with some confidence today. So the first is that force and coercion are part of routine practices in mental health care. And I think that is in some ways kind of shocking that what we see when you actually go in and talk to people, and even in people's stories, but also in the key informant interviews, is that it's fairly routine for people to be involuntarily committed, detained, treated, to experience seclusion and restraints, and not one might argue that sometimes, and we can have a discussion about this. This is not my personal opinion, but one might argue that you might need to use these mechanisms in very extreme situations, right? In very severe situations. But what we're finding is that that's not the case. That this is being used actually in a wide range of situations that don't really call for it, that don't seem to be, doesn't seem to be, even by the terms of the legislation itself, any kind of justification for using it. And that is kind of accepted, even by people themselves who are accessing the system. So comments like, well, it was a terrible experience, but at least in the end, I got some care. At least I got some support, right? So kind of like, oh, I guess it's, it's part of the system. I kind of have to endure this in order to get the things that I need. I have some quotes that will show some of this. Human rights are routinely violated in mental health care. So one of the things you might ask with this legislation, well, obviously it's a huge thing to take away somebody's liberty and to involuntarily detain them. And under the terms, and again, the terms differ in different provinces. I'm going to use BC and Ontario for a moment just to contrast the two. So in BC, it's been well documented that their Mental Health Act is particularly problematic because it has something called deemed consent. So when you come in and you're involuntarily detained, and that usually is like a physician, psychiatrist making that determination, like has your situation deteriorated, are you a danger to yourself or others? There's also a clause in that law around, have you responded to treatment before? Once you are taken in, you are deemed to have consented to everything that follows. So you can be involuntarily treated without any substitute decision maker, without, a family member can't come in and express what you would want. So it's a very problematic law in BC. In Ontario, it's a two-part law. So you could be involuntarily detained and under observation for a period of time, and then there's a second assessment that assesses, are you able to make your own decisions about treatment? And if you are assessed at that point that you're able to make your own decisions, then you cannot be involuntarily treated. So the laws play out in different ways in different context. And in the Kenyan context, they don't have deemed consent either, but it plays out. But unfortunately, often these things come fairly close together, the involuntary detainment and the involuntary treatment. But in the Canadian context and the Kenyan context, as you are being detained, you are meant to be told about your rights. So that's a part of the expectation of the protocols and the law. And you do have access to usually in the Canadian context, tribunals, right? To, get a second opinion, a second assessment to challenge, whether you should be involuntarily detained and for how long. So access to rights becomes a really important question in this context. So even if you are detained under following the letter of the law, are you also given information about how you can access your rights? The other theme, not surprisingly, is that intersecting and overlapping forms of oppression shape experiences of care, especially for poor, homeless, and Indigenous peoples in the Canadian context. And in the Kenyan context, it seems like socioeconomic status is playing a huge role, because in the Kenyan context, as I said, almost all care is institutional care. The big hospital in Nairobi is called Mathare, and when we actually went and visited it before we began the study, and actually one of our team members, Mohammed Ibrahim, trained there way back as a psychiatric nurse, so had some internal connections there. And what you see there is that people, if they have money, they can access, better facilities, kind of nicer care. People who don't have money are kind of in this very, congregate setting, right, where everybody, doesn't, you don't have it's almost like a prison setting, to be honest. That's sort of how it looks. So there's different levels of care that you can access based on class. So that's one of the big intersections that's emerging kind of overall in the project, but also in the Kenyan context, as well as issues related to gender. That's another the intersection of gender and poverty and homelessness is coming up quite a bit, particularly around things like restraints and seclusion, which, for some of the participants, because a lot of the personnel within the hospitals who not all, but some are male personnel, that can be a very traumatizing kind of experience if you're being restrained by a group of male security guards, particularly if you've had any previous experiences of childhood or adult sexual abuse or violence. So those intersecting and overlapping forms of oppression are really important. There's been some, this is where the data is very weak across all of these country contexts, but I don't know how many of you followed, and Benedict, you might be aware of this one at CAMH here in Ontario. There was this internal study done looking at restraints not that long ago, a couple of years ago, and it showed that Black men in particular were disproportionately restrained compared to other populations. There's a lot of research in the UK context that echoes that, also with respect to diagnoses of psychosis, for example. So there's lots of, we do have some data, but this is not being tracked systematically in our systems in Canada or Kenya. So we don't have much data to speak to. And that's kind of one of the findings of the study. You're probably very much aware in the Canadian context and also the Australian context that Indigenous populations, we've heard about the tragic kind of wellness checks that end up in, somebody being shot by police, for example. Those are typically Indigenous people or Black people in the Canadian context, and often in the Australian context. And in the Australian context, they also have, they actually track some of this data a little bit better with refugee and immigrant populations being more subject to involuntary detainment, restraints, and seclusion. And then fourthly, so social and structural causes of mental distress are largely ignored or seen as peripheral. So we're still operating very much in all of these contexts. And this is kind of the legacy, I guess, of colonialism and the kind of Western biomedical approach, which has become kind of the dominant approach within these systems. And that is somewhat tied to the fact that we have systems that are very crisis oriented, right? So systems that don't really allow people to get access to care until they're in a very severe crisis. And so if you're in a severe crisis, you're going to be not doing very well, and you're likely going to be taken in to care through emergency. or, your family trying to mobilize you to get support. So what we saw in our study is that there's a lot of, people get that kind of emergency care, but then they don't get the proper follow-up. And the things that maybe brought them in the first place are not really attended to. So on the next slide, I do want to kind of contextual or give you a little bit of background on I've sort of chosen some quotes, but they're decontextualized and they're kind of dramatic. So I want to just say that from the outset. When we write this up, we're going to give more context to each of these. So, just pulled quotes from stories. At the same time, I think they're really powerful because they do, in people's own words, describe some of what they've experienced. So a little bit of a trigger warning because some of them are quite harsh. So in terms of experiences of involuntary committal and coercion, and I'll just read a couple quickly so that you don't have to try to get it all. So this was a participant in a focus group in Canada. I was put in an isolation room for about 2 weeks and stripped naked, injected and denied access to use the washroom and water, and they were verbally assaulting me. When I was allowed to go outside, I was on the phone with my friend. I was allowed to be out there. I got permission and everything. Then I had some cops run up and tackle me and handcuff me and shove me in a room for 8 hours, and I was all bruised up. Another example in Kenya, I was meant to swallow them, the medications. I'd spit them out, but there was a time they saw me from that day. I hated myself. I was beaten and taken to seclusion for 3 days, and there's an injection you're forced to take. I was injected. I was paralyzed for like 4 days. I couldn't lift myself. So now the people in the same ward would help me to take food. So at that time, I tried going to the clinic officer to tell him I want to go home. I want to go home. Turns out my grandfather and others had agreed that they put me there for 6 months. So they had agreed I stay there for 6 months. So one of the things we're seeing a little more dramatically, although I think it's true somewhat in the Canadian context, in Kenya, family members tend to be very involved because they're usually the front line. And so they tend to be also involved in pushing for, out of desperation, often pushing for needs as a support. With respect to human rights violations, just briefly in Canada, there's a kind of classic example. I don't remember being told any rights when I went in. There may have been some form of signed, after I was in there, some form of sign, I think I meant, after I was in there, but I didn't know where to turn to or what to do. Then I saw a sign on the wall about, I think, what do they call those panels, review panels? And I need a lawyer, but I couldn't get a lawyer. I couldn't get legal aid. I couldn't get anything. So I had to be my own lawyer. In Kenya, I felt violated because why force me? Why not even tell me? Why assume that I'm not well to understand the kind of medication you're using on me? So at that time, I felt very violated. With respect to this notion of intersectional oppressions and structural causes, I'm going to read this one at the end because it's kind of a different than some of the intersections you might think about. So this participant said, so the assertive community treatment team came and the police came to her home. They wouldn't let me get an overnight bag with essentials because I'm a bigger person, and they wouldn't let me get underwear or pads or pajamas or anything like that to take to the hospital. There's nothing like that for somebody my size. They wouldn't let me take my walker, and they made me bump myself down 2 flights of stairs. They took me in the police car, not the ambulance. It was just very upsetting because as far as I was concerned, I was just venting. I wasn't a threat to anybody. This was somebody who was shouting in her apartment and a neighbor called the police. And anyway, so when I get to the hospital, I had to prove I needed my walker. They x-rayed me. And yeah, that was really kind of annoying. And they said, oh yeah, you've got osteoarthritis in all your joints. I thought, well, isn't that amazing? I could have told you that. So kind of an interesting intersection between physical disability and mental health in that example. In the Kenyan context, what I learned is that there's an us versus them environment. They want to show you what we are. They wanted to show you what we are. It looked like a prison hospital. So we used to say we're a prison hospital because they showed you that it is us. We are in control. If you try to, they called the security guards. They take you to seclusion. I mean, they wanted to show that superiority in them. So, sorry, I should have noted with the Kenyan interviews, they were done in Swahili and then translated. So, you're getting a little bit of the mess of the translation still in some of these. And then, yeah, so those are the quotes that are beginning to kind of illustrate these themes. And so in terms of our sort of conclusions so far, is this sort of notion of the normalization of violence and coercion being seen as kind of a necessary part of mental health care. And you probably have followed, you may have followed some of these debates in the media in Canada, particularly it's playing out more in BC because of their act there, but also because this mechanism is being used a lot to deal with poverty and homelessness, right? In Ontario as well. So people's rights are routinely violated in the context of mental health care, and legal safeguards are not particularly easy to access. So what we heard from people is you're in a crisis, you're not doing well. So maybe you come into emergency and maybe somebody tries to tell you about your rights, but you're not in the space. So even if you do get that information, you're not in the space to absorb it. And so people would say, well, I'm not sure, I think, maybe, So how that, whether it's communicated, but also how it's communicated is important. As I've mentioned, the data gap. So regular data collections needed and disaggregated data by race, class, indigeneity, gender, et cetera. And I would say in the Kenyan context, it would be interesting to look at tribal affiliation if that makes any difference. So we need that kind of data. The other kind of data and this is anecdotal still because I haven't analyzed all the key informant interviews, but I did hear in the interviews that I did fairly frequently that people weren't aware of what protocols needed to be followed with respect to restraint and seclusion. I'd say, well, what protocols are you following? Who develops those protocols? Would be like, sure. So that was also distressing that there's not sort of good oversight in hospitals. And then, of course, the colonial history and context matters, and I think this is the piece that we're still developing. And so any thoughts you have on that is going to be really important. And then legal reform, of course, is important, but it's not sufficient. I don't think it's going to get us 100% what we need. So these are just, and then I'll stop for some conversation. These are just some of the recommendations thus far. So, fully committing to implementation of the UN CRPD in its entirety. And Australia and Canada also signed on to a lesser known document, the Sydney Declaration, which was a document that committed to eliminating seclusion and restraints. So reaffirm personhood, engage with dignity and respect. This came up over and over again in the interviews, in the focus groups. People want to be valued as people. They just want to be treated with respect and treated in a caring manner. And unfortunately, it's not that our healthcare professionals don't want to do that. They're often under enormous stresses themselves and unable to respond to those individual needs. So develop skills and capacity of practitioners on best practices that eliminate structural and systemic violence, while concurrently reviewing all legislation to align with equity and human rights for all. So training and capacity is coming up as a huge issue. Embracing intersectional frameworks, and I would add here decolonial frameworks for understanding and responding to emotional distress. And then there's an interesting document, I don't know how many people have seen it, the WHO did a project, and this is a whole other conversation, that looked at community-based mental health services that align with human rights. And some of the work that we are doing in this project is also engaged with that. We've done the critical realist review and the environmental scan. So there are really good examples internationally of how to do this better. So sort of recommending the scaling up of that, the recognition of that. And then I just want to also, in all the talks I do, I want to sort of recognize, the people on the ground, particularly the people with lived experience who've been raising these issues for decades and decades, and putting their voices out there, often at great risk to their own mental health, but also to their ability to get care and support. I just want to recognize them in their efforts. And just to conclude, so as you know, there's a number of next steps. I can talk a little bit about some of the knowledge mobilization activities we've done, if that's of interest. But I think I'd like to just open it up all to you to comments, thoughts, questions.
Yeah. Wow. That's a dish.
It's a dish, yeah, probably a lot.
That's everything.
Probably too much.
Just a very quick reminder on within this question period, and thanks for agreeing to take questions. When asking questions for our speaker, please be sure to enunciate and speak loudly toward the camera. This way, everyone online and the room can hear you and your question clearly. So hopefully we'll be able to pass this on as well.
The microphone's right at the front, so
and-
just talk towards this.
Okay, just talk towards that. So that's the 360 thing, correct? Okay, great.
It's great room.
Okay, so yes, and hopefully you'll be monitoring online for me to see whose hand is up. Okay, questions? Yes, please.
Thank you for the presentation, Professor. I'm a PhD student in the School of Global Health, and my research focuses on people living with dementia. I've come across this sort of thing in my work as well. And what I was thinking about reading the paper as well was sort of the role of intergenerational trauma in a lot of this work. So one participant I spoke to when I was doing my master's thesis, she had a lot of guilt around sedation for someone living with dementia in her life, but it was sort of the cultural norm in where she was to use that as a management strategy. And then in the article, it talks about intersectionality and sort of colonialism, but we also know that historically that has added to the burden of certain underrepresented communities in research with wealth, with like the social determinants as well. So I was wondering if you'd speak a little bit about the intergenerational trauma in your research, if you've come across it.
Yeah, thank you for that. And also just to comment on the dementia piece and seniors in long-term care or in institutional settings, there's so many overlaps. Like I think that would be a really interesting investigation. Sounds like you've done some of that work. There's so many overlaps, I think, with those pieces. Yeah, the intergenerational trauma, I think that's a really, it's not something we've tracked specifically, but it's definitely something coming up in some of the stories, right? That people have, especially in the sample here in Ontario, where a lot of the people that we've that came to the focus groups were people who had, long-term, street involvement, alcohol and substance use issues, and they had just encyclopedia knowledge of the Mental Health Act because they've been subject to it so many times, some of these folks. But in their stories, there was a lot of that that historically, particularly around the foster care system. This came up, I think it was an Indigenous participant who talked a lot about their experiences in foster care and how that set them on a particular kind of path and experience. So it's something, it's actually a reminder for us as we're doing this work to really be attentive to that, because I think it plays a huge role.
Just let me just say quickly, if you've not met already, before you speak, you can just say your name so that at least we get to know, at least you get to know. And I guess this is Rushbrook, right?
Rupcha.
Rupcha, yes, that's good. Yes.
Thank you, Dr. Morrow, for your presentation. I really appreciate how you mentioned that it kind of reminds me of the phrase the tyranny of the biomedical, how that always supersedes the importance of the social determinants, which are sometimes we have to, I think when we talk about biomedical urgency, we need to qualify it more with respect to social determinants, which I sometimes don't see. So I was wondering if you might be able to discuss I know you used the term critical realist. So I'm wondering if you'd be able to discuss critical realism with respect to that fine line between making sure that we don't forget the biomedical, that's undeniable, but also that we intertwine that with health equity and with respect to social determinants as they are applied to minorities or.
Yeah, excellent question. Yeah, I mean, I think it's so interesting because I agree with you. You can't ignore the biological, right? And in my work, I feel like I'm a bit of a broken record on this one, but I'm always saying, that what we need to do is rebalance our understanding, right? So we have psychiatry has come for all sorts of historical reasons, and also for, I think, they've come to dominate, right? They've come to dominate the understanding, right, of mental health and well-being. And absent from that are people's own embodied experiences of this, some of which include, of course, the kinds of the severe suffering just of the symptoms and that experience itself, right? So my kind of railing against biomedicalism is not to say that these things aren't real or that people don't experience this or that there may, somewhere be a biological connection, but as you know, the evidence is really poor still, right? Even if you read psychiatrists' work, they will say we haven't found, they haven't found a gene for any of these, there's no gene markers, there's no, the evidence is poor around the biomedicine side of this. which doesn't mean we shouldn't, still pursue and try to understand that piece. But what we see now is a system, and I think it's reinforced by a number of things. It's reinforced by neoliberalism. I think the shrinking of social safety nets, the kind of ways in which people are falling more and more into poverty and homelessness, and that kind of interconnection. Like if you're unwell, you're more likely to fall into poverty. But if you're living in poverty, you're more likely to become mentally unwell. So you have those kind of interconnections, but also discursively, this sort of idea that it's all about you as an individual. And now there's a lot of uptake, and it's partly, I might be going on a tangent here, but it's partly the result, I think, of anti-stigma campaigns, that we've destigmatized mental health. So now, particularly, I think amongst younger populations, there's an uptake of these labels. I'm depressed, I'm anxious, I'm ADHD, I'm this. So on the one hand, that's maybe a positive thing, right? But it also has this unintended consequence where it kind of reinforces this an individual illness, right? Any illness is contextual, right? We know, even if you have cancer, your outcomes are going to be different, depending on where you live, depending on your gender, depending on your race, depending on, how quickly your family background or cultural beliefs, like these are all, whether you have a public healthcare system. So all of these experiences are embedded in the social. And I think that's the piece that keeps getting ignored. And then when you have on top of it a system that's so crisis driven, there's no time, for, the types of professionals that are involved. So you see when people are going into emergency, they're not getting necessarily, psychiatric specialists right away, right? They're getting the emergency docs who have to make these really quick decisions about what to do. Do I keep this person? Do I send them out, right? So it's a system-wide problem. I think there's widespread recognition that the social determinants are important, but we don't do it very well. We don't have the access to care that would prevent you from deteriorating so far that you have to go to emergency is often absent. So I think the critical realist framework is a good one. And it makes me think also of like sort of critical disability studies that was sort of moving beyond the social model. The social model has been so important, but that sort of, the embodiment of illness, what's that like for people? And we don't want to ignore that, right? We don't want to ignore that real distress or trying to better understand kind of the brain and how this happens for people. Right? I don't know if that answers your question, but that's.
That really helps. Thank you.
Yes. More questions?
Yes, I'm Kadir. I'm also a PhD student here at Global Health. So my question is related to, there are some inquiries maybe I needed because I'm new to this place. With related to the Mental Health Care Act, whether the Controlled Drug and Substance Use Act of Canada is part and parcel of it, or it is both are separate?
My understanding is they're separate. So right now, and I believe this is, I've only studied sort of Ontario, BC at depth, but my understanding is that addiction cannot be used as the sole reason to be taken in under the Mental Health Care Act. At the same time, because addiction and mental health issues are so interconnected, many people do end up, being involuntarily detained who have both of those things. But they're separate.
So related to it, so whether there is some kind of teams coming up intersecting this, because substance use disorder itself is a mental health disease. And then, but in case of substance use, which we find in the community, then the legal enforcement is so strong for the substance use compared to the simple mental health care. So how these kind of interlinkages in producing this involuntary or some kind of coercive practices just happening for the people using these substances and linked to the mental health?
Yeah, it's a really good question because again, if you follow, I don't know if you follow kind of the news around this stuff, but in both in BC and Ontario, this comes up fairly frequently because of inner city, particularly, it's even happening in much smaller cities now, but the rise of like poverty and homelessness and that interconnection with mental health and substance use. And so, governments are struggling to figure out how do we get people care, how do we support them? And the Mental Health Act is actually being used as a mechanism to get people care. That's another kind of underlying finding, I would say, in our work. And that's where that tension comes in, because people who work in the field will say, well, if I don't use the Mental Health Act, this person will just stay on the street and not get any care, right? So is that a justification to take away all their rights and have these kind of experiences? It's a moral discussion, right? So I think increasingly the Mental Health Act is being seen as a mechanism to force people with addictions into treatment. And it's been quite explicitly so in the BC context, where there's been bills introduced and then rejected in order to widen the Mental Health Act to commit people with addictions. So.
There's one more question. So you were mentioning that the system is allowing people to progress to a severity of the disease, mental health disorders. So does any of the study sites, Kenya or Australia or BC or Ontario, so does they have some kind of screening mechanism or preventive mechanism for the prevention of mental health disorders in their routine population?
Yeah, so I mean, again, it really depends on where you're located, your ability to access supports. And so, you know, the more privilege you have, the better set up you are. So for people here at the university, though I hear access can be difficult still, you know, we've got counseling. There's so many different counseling services and supports that people could access fairly early on. Primary care doctors are often the kind of first place of access for people then to access psychiatry, but there can be very long waits to get a psychiatrist. So to get an actual diagnosis of what you have, you could wait 6 to 8 months sometimes before you can get that diagnosis. If you're living, you know, rural or, you know, northern communities, psychiatrists are less available. So it partly depends where you're located, what kind of access to care you'll get. There are some very good community supports, and if people are able to access that early on, then they often do very well and avoid hospitalization. So bearing in mind the population we're looking at are the people that, you know, have gotten to the point where they've had to be involuntarily detained. So it's sort of at the more extreme end. So there, you know, there are people that do get supports and care, but it seems to be very much tied to geography, availability, and people's social locations as well.
Thank you so much. Yes.
Sorry, my name is Latika. Thank you, Dr. Morrow, for your presentation. It's really interesting. I think my question is around just based on the results and the data that you've gathered, has there been any success stories or anything that you found maybe interesting that came out of the focus groups that were kind of just seeing a little bit positiveness in like how progression has been made, legislation or the laws that we currently?
Yeah, so it's good. Again, this seemed to differ by class in a sense, like by people, you know, people who had some money and education, they seemed to do better, like they had more access to care. We did one of our focus groups, I should have said this in BC, involved, it was just 2 people, but it was caregivers, and we weren't planning to do caregivers in this particular study, but they were really insistent that they wanted to talk because they had very complex stories. But what was interesting about that is that they were really navigating the system in a, you know, in a way that many other participants just could not, you know, and so the outcomes for their family members were a little bit better. You know, and we did have some positive stories. So the positive stories were usually around, again, this a bit of the normalization of the violence, like, okay, I experienced this, but I did then get care, and I did then get connected to a community organization, and now I'm, you know, I'm working again, I'm doing well. Some people said, you know, I encountered a, you know, fantastic, you know, nurse or a fantastic psychiatrist that really made the difference, you know, in terms of how I was able to, you know, recover and do better. So there's some of those kind of individual stories. I think on the kind of the larger systemic piece, it's been a little bit harder. You know, we've connected with a lot of advocacy groups and rights groups, and it seems to me there's a real disconnect between sort of disability rights, activism internationally, and mental health is still kind of marginalized in that space, not as much recognition. And so, so that's part of the reason we have such a big international advisory, is that we're trying to really cultivate the awareness. Some of the folks that are on those teams work more in the disability space. And so we're trying to create a broader kind of network of people that can do more advocacy work around the mental health piece. And the discussion around human rights in Canada is completely absent around mental health. There's no discussion. Every policy document I looked at, nothing. Australia talks about human rights. Kenya talks about human rights. Like, maybe they may not be implementing them, but in their policy documents, it's front and center. In Canada, you can't find even the word human rights in any of the, you know, national strategies or provincial strategies. It's just not there. No discussion, which is concerning.
That's surprising. Yes. Any more questions?
To
Folks online? Yes, yes.
your
Sure.
point about like sort of the tie between human rights and mental health. I also like just anecdotally, like I have friends who are members of the trans community and getting support for both of their mental health and also their transition journey is just very difficult. Like I know CAMH now has like supports for people who are transitioning as well as who also have diagnosis of mental health, but it's still so tricky. Like the wait lists are so long that it takes forever to even access.
Yeah, and you're also in this kind of position where in order to get those services, you have to actually go through psychiatry. Like psychiatry is the gatekeeper, right? And so what I'm also hearing, and this is not part of my study, but just again, through people I know, a lot of people are informally getting, going online, accessing hormones, so they're not under medical care even, in part because it's so hard to access that. It's huge.
So my name is Meenakshi Das, and I'm part of School of Global Health. My question is that since they don't talk about in any of the provincial and Canadian provincial as well as the strategy of human rights in practice, so how can we make a practice of the patients, that have been suffering in mental health situations, but we don't discuss about that. That's in disguise. So how in practice it's possible to get that human rights notion into action?
That's the $1 million question. I think there's a number of different ways. One is I think, of course, there is the legal route, and in BC, I don't know how many of you followed it. There's a charter challenge that's been going on for a number of years. It's been blocked by the government for many years, but it's now apparently going forward against the Mental Health Act. So, legal mechanisms, as you know, can be helpful for raising awareness. They may not make, widespread system change. It'd be interesting to see what happens when that case gets heard. So that's one way. I think the other way is to, to really advocate for these community-based and peer-based kinds of supports. Over and over again, that's what we see in the literature, that those are the kinds of supports. Once people are through, they might need medical attention at a certain point in their journey, but once people have had that medical attention, it's really those kinds of supports that are vital. And that, and it's connected to, don't vote for Doug Ford, vote for somebody else who's going to, make sure that those systems are robust, right? And that they can support people, because I think that's so using our citizenship and our vote is really important, but also, I guess, raising awareness, wherever we are around these practices, right? Not normalizing it.
Yeah, it's it's needed during the service delivery of in the hospital.
Huge. This is coming up a lot in the study, the training and education issue. And yet we also know those healthcare providers are under so much stress. They often themselves experience, violence and discrimination. They're disproportionately racialized depending on where you're positioned within the healthcare system. So those experiences, it's very complex. And we certainly don't want our study to be looking like it's blaming healthcare providers, because I think they're doing what they can within these very constrained systems. But at the same time, there's room for more, trauma-informed care is a really good mechanism or lens to use. I think that kind of nicely intersects with kind of like a decolonial kind of perspective as well.
So then are you coming up with a framework for the human rights framework for the mental health people?
That's the intention. Yeah, I think we're going to have to seek a bit more funding to get to that place, but that's definitely what we want the outcome of this, one of the outcomes of this to be.
Yeah, I can see Balu online. Go for it.
Good morning, everyone. So I'm Balu Lumor, PhD health student. Thank you for that great presentation, Professor Morrow. My question was just surrounding the Mental Health Act and the migration trajectory of the participants. Was there any findings in terms of that intersectionality, let's say folks who are at detention center or who are undocumented in that sense?
Yeah, thank you for that question. I don't feel like we've captured that in this research, to be honest. I think it's a really important piece and a very, again, kind of a piece that's not well researched or well documented. I do know, I mean, there's some very, and I know you're aware of these stories, but there's some very high profile cases in Ontario that we've heard of, over the years where there is that intersection, right? But I think in general, so in our focus groups, that didn't come up. We didn't really have anybody, I think, that had followed that particular trajectory. But I would say it's one that is understudied and needs to be examined for sure.
Any more questions now? Okay. Great. Well, and a round of applause for I think it's been very, very